Dr. Jeff talks love, Dr. Jeff talks life, answers your questions, cuts through the strife. Sex and intimacy, real and true, evidence-based, made just for you.
Hello. Welcome to Dr. Jeff Talks About Sex and Intimacy, the podcast where we explore the real, raw, and the relevant aspects of sexual health, relationships, and everything in between. Thank you for joining us today live or on the recording for episode 36, When Sex Hurts, helping women move past pain back to pleasure. I want to say a word tonight and focus on gratitude. This came to me while I was kayaking on the Chicago River today in this most gorgeous, tremendous, beautiful, miraculous day we have here. Fall is like the greatest season in Chicago, and we had perfect weather. So it came to me how important gratitude is. Gratitude research shows that practicing gratitude enhances mental and physical well-being by increasing happiness, and this is science-based, increases happiness, reduces stress, and improves sleep. Practicing gratitude can also foster emotional resilience. We all need more resilience. Lower cortisol levels, that's that stress level, stress hormone, and improves cardiac function. Amazing research that says gratitude is sort of the bomb. It's a big deal. I'm so grateful for so many things. Today, I'm unbelievably grateful for this gorgeous, beautiful day in Chicago. The water was glistening. The sky was blue. It was absolutely breathtaking out there. And very low humidity, just absolutely amazing. I'm thankful for so many things. I have this amazing wife of almost 40 years who puts up with me doing a podcast on Tuesday nights, and she goes out and gets out of the way so that this can all be done, and just is so supportive and wonderful, and I can't fathom my world with anyone else but her. I'm so blessed to have found her. So I'm really grateful for her. And I'm grateful for you, the listeners. Thank you for being here. You know, your presence is everything. You're the only reason this podcast exists. This is the whole reason that we do the podcast. I am so truly grateful for each and every one of you. What are you grateful for? Today, believe it or not, is Hunger Action Day. So many people in the world are hungry. And I think, wow, I had this incredible meal. I have amazing food in my refrigerator, and I tomorrow evening I'll be cooking a meal. My wife cooked an amazing meal tonight. Half the world doesn't have clean water. I just hit my faucet and I have clean water. What are you grateful for? Think about it and take that grateful moment to know the world is miraculous and wonderful, and gratitude is powerful. Well, we are on social media. We're out there on Facebook. We're on YouTube. We're on X. Lots of people watch us on X. Thank you so much for doing that. We're on LinkedIn. We're on Kicks. If you're on X, though, and you need to submit a question, you can go to StreamYard, you can go to Facebook, you can go to Kick to submit those questions, and we're happy to answer those questions. If you're a Facebook person, the more people follow us on Facebook, the more we can do on Facebook. So please follow us if you're a Facebook person. Go to the website. The website is where you can watch the 30 some odd previous episodes with all the awesome guests that have provided incredible evidence-based information for you to learn more about relationships, sex, and intimacy. So go to the website and you can pull up the calendar if you're like, what's next? We're going to tell you about next week, but you can look at all the weeks, all the way to the end of the year. We're almost programmed completely. I think you have 3 weeks that aren't programmed yet, all the way to the end of the year. So there's lots of great guests coming up. So please go to the website to find out more. We're where you are. Listen to us in your car or wherever you are on your favorite music streaming. If you love Spotify, if you love Amazon Music, if you love our iHeart Radio, listen to us while you work out, while you're in the car, wherever you are, we're there with you. I want to remind you this because this is so important. You are welcome. You are so welcome here, whatever your sexual orientation, whatever your gender identity, whatever your relationship style is, you are welcome in this space to learn, and we are so glad that you're here. So the goal of the podcast is pretty simple. It is just to empower and enlighten you with the evidence-based scientific information you need to move forward, to have a better sexual life, to have a more deepened, amazing relationship with that person you love. In fact, and if you haven't selected that person you love, we are going to have a great episode coming up. Look on the calendar about how scientific information about how to pick and find a mate. Pretty cool. Our guest wrote a book on that, and I'm very excited about that episode. So that is the goal of the podcast. It's all about you, to enlighten and inform you, to help you have a better sexual health life, as well as a deeper, more meaningful relationship so you can live and love more purposefully and more fully. Tonight is a great night. I am very, very excited about tonight. We are going to talk about a common problem for women during sex, and that problem is pain. In this conversation, we're exploring one of the most important and often overlooked areas of health, helping women move past pain back to pleasure. And this can be especially challenging with a history of sexual trauma as well, or physical trauma. I'm so grateful for my guest, Dr. Traci Kurtzer, a leading expert in trauma-informed gynecology and women's health. I worked with Dr. Kurtzer for many years up at North Shore and also when she was at Northwestern, and we had many common patients, and I can't think of anyone better in the Chicagoland area to refer my patients to than Dr. Kurtzer. She is amazing, and I will talk more about her in a minute. But also, now you ought to know by now, because she's been on the podcast twice, and she guest hosted for me while I was in the Northern Rockies. But my co-host tonight is Dr. Susan Kellogg-Spott. I'm so grateful for both of these wonderful experts to share their expertise with us tonight. And we're going to have a great discussion. Together, we're going to talk about how past pain and trauma can impact sexual health, all the different factors that factor into pain during sex, intimacy, and relationships, as well as practical and compassionate approaches to dealing with pain and moving towards health and healing, which is our goal. This episode offers hope, tools, perspective on reclaiming sex and intimacy after pain and or trauma. So my guest tonight, specifically our guest, Susan and I, Dr. Kellogg and I's guest, is Dr. Traci Kurtzer. She is a board-certified obstetrician gynecologist and retired clinical assistant professor at Northwestern University Feinberg School of Medicine. As the medical director of trauma-informed care at Northwestern, she started the first Chicago area dedicated clinic for follow-up care for survivors of sexual assault and abuse. She dedicated her clinical career to providing trauma-informed, patient-centered care for patients impacted by sexual violence and vulvovaginal pain disorders. She currently serves as the medical director of Trauma-Informed Solutions for Healthcare, doing consulting and advocacy in this space of providing trauma-informed medical care. Nationally recognized for her expertise, Dr. Kurtzer lectures widely on sexual health and trauma-informed gynecological care for survivors of interpersonal violence and sexual violence. Her compassionate, innovative approach has helped transform how clinicians support survivors in their healing journeys, thus empowering patients to feel safe in the exam room and reclaim their self-confidence and re-embrace intimacy in their lives. So I am so excited to welcome my co-host, Dr. Susan Kellogg-Spatt, and our guest, Dr. Traci Kurtzer. Welcome.
Hi, Jeff. Hi, Tracy.
Hey, good to be here.
Wow. Thank you so much both for being here and sharing your expertise tonight. So we're kind of starting to infuse the podcast with gratitude because I think it's so powerful. I just wondered, what are you guys grateful for tonight? What are you most grateful for? I'm sure there's a list of things, but tell me a couple things you're grateful for.
So many things. I really believe in gratitude as well, Jeff. I really try to focus on all the things we really have to be thankful for. I think when you put that positive energy out there, it comes back, manifests in so many ways. So absolutely, the gorgeous sun and weather and hearing the crickets and seeing the bees floating around the flowers on my porch. I'm grateful to be able to live in a space where I have nature around me every day.
Yeah, you are an amazing gardener. I've seen the fruits of your labor and they are something else. How about you, Dr. Kellogg? What are you grateful for today?
I am thrilled because I am just enjoying fall so much. And one of my favorite things is golf. And I love fall golf because I'm not all sweaty and gross. I just love to hit the ball or even miss the ball, because on a beautiful fall day when there's leaves on the course and there's friends to be with and laughter to be had, it's all great. And I'm just really pretty happy for my life.
Wow. I agree. Gosh, all of us have so much to be grateful for. And I'm sure listeners, you have a lot to be grateful for too. So think about it. What are you grateful for? Well, without further ado, I am so excited about your presentation, Dr. Kurtzer. So I'm going to hand it, Dr. Kellogg and I are going to hand it right over to you now.
Sounds good. Let's go. Have no fear. Help is here. I really don't have any significant conflicts or disclosures. As Jeff mentioned, I'm a retired clinical assistant professor at Northwestern and worked in the Center for Sexual Medicine and Menopause there, where I saw many patients over the years who were dealing with sexual trauma and pain disorders. And we talk about this pain disorder as a female sexual dysfunction, but I do want to also be very inclusive and let everybody who's listening know that we're talking about those who have female anatomy. So no matter what your identity is as a human being, this may be applicable to you if you have female anatomy and are dealing with pain with sexual activity. So hopefully at the end of this presentation, you'll understand some of the different causes, the hormonal and physical structural types of issues and psychogenic causes of one type of female sexual dysfunction, which is sexual pain disorder, and understand when to request for evaluation, what to kind of expect during a sexual health exam to maybe demystify it a little bit, make it something that seems like more less scary, something that you may be able to do if you're dealing with this. And then also so that you have some background knowledge so you can really effectively communicate with your healthcare professional about some of the different treatment options, what might be going on, and also to ensure that your care is trauma informed. And I'll talk a little bit more in depth about that. And sexual function is important. I'm sure you've seen this data before from Dr. Jeff. Sex is such a vital part for most humans' experience, but not everybody. And if it's not important for you, that's okay too. But for many people, it is important. And so when and throughout different ages, women engage in sexual activity. But when there's a dysfunction, if things aren't working as well or as optimally as they can, it can really be hard on people, really hard emotionally, and also affect relationships as well. The study looking at female sexual dysfunction that looks at how prevalent it is, really we kind of categorize significant sexual dysfunction when it causes distress. So although arousal disorder, where there's difficulties with maybe lubrication or the clitoris engorging, or desire disorder, where it's hard to get kind of a normal libido, or orgasm disorder, like even though that's fairly prevalent, if you look at those numbers on the slide, when it causes distress, we're really looking at about like 10 to 15% of women that self-reported. But what I will say is pain disorders really are involved in all of these. So if there's pain with sexual activity, there's probably going to be a desire disorder. There's probably going to be an arousal disorder, and there may be some impact on orgasm as well. So it really kind of overlaps with all of these other conditions across the board. Okay. Oh, there we go. The other thing that I just want to point out is by age group, although we look at pain disorders overall, and they maybe affect around 10, 11% of all women aged, I think that's 18 to up to 100. If you look at postmenopausal women, the 55 plus crowd, you can see how pain really becomes a much more significant problem. And the reason for that is estrogen deficiency. So this is a list, kind of a busy slide, but it lists all the different causes of pain during sexual activity. So there's some superficial causes, and then there's some deeper causes that cause more like pelvic type pain syndromes. For the superficial causes, one of the most common ones is estrogen deficiency. I know for a fact this has been covered before, but I'm going to just kind of talk about it again because it's so prevalent, so common. And what we see with estrogen deficiency, whether it's due to menopause, which the term we use for that is genital urinary syndrome of menopause, or it could be because of estrogen deficiency for other reasons. Maybe you're on medications that's inhibiting your estrogen, and that will cause the same effects of vulvovaginal atrophy. So basically, vulvovaginal atrophy is thinning of the vulvar and vaginal tissues. Because they get so thin, like the right side of the picture, if you're looking under a microscope, they're prone to break down. You can get little tiny micro tears that sting and burn. There can be, larger fissurings that sometimes actually bleeds. Definitely a feeling of dryness. And because there's less of those cells there, a loss of natural lubrication. And when there's not normal lubrication and slipperiness with penetrative activity, it's going to hurt. It's going to feel like a rug burn happening. These changes also can happen to the urethra and lower bladder. And so there's a propensity towards urinary irritatives kind of symptoms like urgency or frequency, or even urinary tract infections as a result. And if we associate having penetrative sexual activity or any sexual activity with developing urinary symptoms that can be so painful, that's going to be a really negative feedback loop to the brain to want to engage in sexual activity at all. If things get really severe in atrophy, there can actually be some structural changes where the vaginal and vulvar orifice starts to constrict, or what we call introital or vaginal stenosis. And there also can be a sense of kind of a bracing or guarding effect where the pelvic floor muscles will get involved and actually cause tension around the vaginal opening too. All of those creating a very constricted passageway. Sometimes for some patients, sex becomes basically, you just can't do it. It's just unfeasible. There's no way a penis or a toy is going to fit inside. So dealing with any estrogen deficiency, super important. Getting it evaluated, figuring it out, and I'll go over some treatments in a bit. The other two things that I wanted to really put a lot of attention to today is pelvic floor vaginismus and vulvodynia, two vulvar pain conditions that are so impactful because they have high connections to trauma histories as well. And this is a super busy slide, but it does have some really important data. Feel free to take a picture if you want to kind of review it later. But basically, vulvodynia basically stands for vulvar pain. Can be burning, stinging, itching, irritation, throbbing, located in the vulva. It needs to be there at least 3 months, and there's no obvious explanation for it. Now, there can be different kinds of vulvodynia. For some people, it's lifelong. They've had it since they can remember touching their vulva. For some, it's acquired at some point in their lifetime. It can be localized to a very particular area of the vulva, or it can be all over to touch. It can be essential, which means it's there all the time. You're just sitting, you wake up in the morning, you feel your vulva stinging. Or it can be provoked, meaning only with touch do you feel that discomfort. This is a very difficult pain for patients to deal with, for women to deal with. Sometimes it impacts sleep, like I said, if it's that essential type. Sometimes it affects what you wear, clothing, activities can be affected. Maybe you can't go biking. You love biking and now you can't bike anymore because you have this pain disorder. So it really takes a toll, emotional toll. We see very high levels of depression and anxiety associated with this condition when it's not addressed quickly and dealt with. And then the second one is vaginismus, which is basically persistent difficulty with some type of penetrative activity. You know, typically we think of sexual activity, sexual penetration, but it can be also related to other forms of penetration, like having exams or procedures done where there needs to be, like ultrasound's a common one. A probe sometimes needs to be inserted inside for certain types of pelvic ultrasounds. So if there's, an association of difficulty with that, and it doesn't even necessarily have to be pain. Sometimes it can just be the fear or anxiety and anticipation of it. But what we commonly see with this is there's like a very marked tightening of the muscles in the pelvic floor, particularly around the opening or introitus, that basically make that penetration almost impossible. Again, can be lifelong, can be acquired, can be generalized, meaning happens with any type of penetrative activity, or it can be very situational. Maybe it's just with sexual activity. Maybe it's just sexual activity with one partner. Could be just with gynecologic exams, something that I would see a lot in my practice. So, the situation and all these different explanations for why it happens can be variable, but the one thing that's consistent is it's always provoked. It's not just there while you're sitting around. So it can have a different kind of set of emotional toll because it can really limit sexual activity or getting preventative exams. But it has a little bit less impact day to day. It's a little bit more easily avoidable. But the problem is it's easily avoidable. And that's what women tend to do, is they tend to avoid those activities that cause pain, right? Because our brains are not stupid. We don't run out and want to engage in things that cause us pain. We're going to get into some avoidance behavior when we have that association. So what we see with both of these is each attempt at penetrative activity typically is going to worsen the pain until it's addressed. High levels of past sexual trauma associated with both of these syndromes. And then unfortunately, medically induced trauma. And trauma reactions are super common during gynecologic exams. So if you can think of an exam where you start hyperventilating, you start crying or wincing, you start closing your knees together, that is a trauma reaction, meaning you've had trauma in past experiences, whether it's with sexual activity or an exam, and you really, really deserve to have a skilled clinician working with you to get the evaluation done so that we can minimize re-traumatization. We don't want to layer another cause of pain because the brain remembers. So let's see if I can get this to advance. Sorry, my slides are being a little persnickety. Are those advancing? Because I'm not seeing it on my screen. Okay, well, so sorry, because for some reason I don't seem to be working here. There we go. Okay. What's involved in evaluation for female sexual disorders is first, there's a screening questionnaire. Skipped a few slides there, but that's okay. There is a screening questionnaire specifically for vulvar pain. It's pretty long. It's like 38, the short version's like 38 questions, but it can really help to pinpoint some of the issues going on. Second part of the evaluation is going to be a review of that hormonal status and some different medical conditions or medications that can impact and cause pain and cause atrophy and dryness. We're not going to cover those right now just because I really want to focus on the genital examination. So what is involved in the genital or gynecologic exam? So this is the external genital or vulvar, diagram. So hopefully you all are fairly used to looking at this now from being on prior podcasts, but I think it's really important for us to know everything outside of the vaginal canal up to the lateral aspect of the thighs and to the anal area is part of your vulva. And when we talk about vulvar pain, again, that generalized pain, it can be anywhere along that entire region. But those area where I have the arrows are very common areas for pain. That area is called the vestibule, kind of the entranceway to the vagina for pain with vulvodynia and vaginismus. So if your pain is kind of localized there, if you know from touching or just from where you feel discomfort, it's very possible that's what's going on, is that one of those conditions is present. To do an exam, we also need to evaluate, going back, I'm going to go back to the vulvar exam. Other than just doing a visual exam and looking at kind of the tissue health and are there any other explanations for pain, one of the tests we do is called a Q-tip test, and it's basically taking a lubricated Q-tip and touching in the different areas of the vulva so that we can really pinpoint where that pain is coming from. If you have fear, if you do not like having Q-tips there touching you, you can ask for something else. We can use a lubricated finger. We can use the tip of another instrument like a dilator to also elicit and kind of determine where the pain's coming from. So you have control over your exam, but that's what a Q-tip test is. For the pelvic floor, to evaluate, are there areas of tension? Now, sometimes when we're doing an exam, we can actually see those pelvic floor muscles tensing and contracting, even without palpation or touch, particularly with vaginismus or with like the Q-tip touch test or with anticipating touch. If you see those muscles contracting, that literally is vaginismus right there. But also using a gloved finger, we can just touch on the outside in that area where I have the oval, the lower part of the bulbar cavernosus or bulbospongiosus muscles that run on either side of the vaginal opening, or the transverse perineum, which are those lateral muscles that come in. Those are really common areas for tenderness and pain to touch. And then we can also do an internal exam where we insert our finger inside, and this tube kind of represents where the vagina sits. So you can, with a finger and digital exam inside the vagina, feel deeper muscles that might also be tense and might need to be treated. If vaginal approach is really undoable, somebody has such severe vaginismus, but that nothing can get inside, not a Q-tip, not a little pinky finger, nothing, then those muscles also can be palpated from a rectal exam. It's not fun, but some people, actually do better with rectal examination of the pelvic floor muscles when they are getting their evaluation than having a vaginal exam. And, some women also find that they are able to have anal sex as compared to vaginal penetrative sex as well for the same reason. All right, so treatment. I want to spend a little bit of time here just talking about this cycle of pain. And I think we'll touch on this a little bit more, but for whatever reason that sex or a penetrative activity initially causes pain, it can set off this whole cycle that kind of layers the pain over and over and over again. So maybe there's a psychological cause. There's just an inherent fear of some penetration, a phobia to it. Maybe there's been some trauma. Unfortunately, sexual violence is so common in this country for women in particular, men as well. But basically, traumatic history, fear, those are kind of the psychogenic causes. Then there may be physical causes for pain too, some of the things that I spoke about already. When there's pain, the muscles tense up. The tightening itself, tense muscles cause pain. I mean, think about it. You get a Charlie horse. When you first go down to rub that Charlie horse, it hurts to touch those tense muscles. When you have a sore shoulder muscle and you touch it, like right now, to try to massage it, it hurts a little bit. So if you have pain right at the entrance and now you're touching it or putting really extreme pressure on it, it's going to add to the pain. So then it becomes layered, right? The body also reacts by bracing. It prepares, it anticipates pain by constricting and tightening even more in all of those muscles, not just around the vulvar and vaginal area, but everything, the thighs, the hips, the back, everything gets tense. And then the body starts to associate that penetrative activity, whether it's sex or an exam, with multiple layers of pain. And then it happens, there's penetration, and everything gets set off again. So basically it becomes a very cyclical cause of worsening and worsening pain. And that's why it's so important to have a trauma-informed practitioner, because we want to minimize, we don't want to contribute to that cycle of pain, right? It's already there, wound up pretty tight. We don't want to be part of that. When it comes to vulvovaginal atrophy, or the GSM for menopausal women, there's lots of treatments. There's over-the-counter moisturizers. There's prescription vaginal estradiol. It can come in cream or suppository form. There's vaginal DHEA, which is a precursor hormone to estrogen and testosterone. There's an oral medication if you really have trouble with placing products or inserting products in the vagina. There's actually an oral medication that's appropriate for some patients. And then there's laser therapy. So there's lots of treatments. You need to go get it figured out. If there's that stenosis or tightening or shortening or constriction, that's where using vaginal dilators, pelvic floor PT, getting our physical therapy colleagues involved can really make a big difference. Sometimes surgery, sometimes there's a band or a constriction that needs to be surgically corrected. Again, seeing a specialist, it's worth it to get that level of care. So that might be a sexual health specialist like Dr. Albaugh. It could be a gynecologist who has some expertise in this area, or urogynecologist. But just, read the bios or read the website, and you can even call and find out if sexual health, vulvar pain is an area of expertise, because you really deserve that level of attention to getting the diagnosis correct and not contributing to more pain for you. Vulvodynia and vaginismus, quite complex. And again, in addition to treating certainly any underlying vulvovaginal atrophy, we do want to take a multidisciplinary approach to that, working with a skilled practitioner. Again, that's your clinician who's going to be prescribing medications, maybe to help with some of the pain management, modulating some of the pain with medications. Those can be oral, those might be topical muscle relaxants, medications like that. Like that's the job that I would do. But I would use my colleagues, my physical therapy colleagues who are specialists in pelvic floor. They would work with the pelvic floor muscles and some of the desensitization and the dilator work. I would use my sexual therapy colleagues or trauma therapy colleagues to do the talk therapy part, right? It really turns out that doing some work, particularly with vaginismus, which is a difficult condition, that it turns out much of it is very fear-based. It's a phobia disorder, basically. And there can be trauma connections as well. So we really need to work on the talk part of it and some coping mechanisms as you're going through the treatment, as you're working with me, as you're working with the PT. What are some coping skills to use to kind of handle some of the natural discomfort that comes with the work that has to happen? But it can work. And if it's a phobia to gynecologic exams, you can do desensitization or what we call graded exposure work with gynecology exams. That's what I used to do. I would take patients who'd never been able to have a gynecology exam before and get them so they could have that pap smear, so they could get that pelvic ultrasound that they needed done by just doing it stepwise, just addressing the fear by stepwise exposing you or the patient to the next part of the exam. What's the next step? And we just would do it stepwise. So it wasn't overwhelming. You didn't have to do it all at once. And if you didn't do it that day, that's okay too. No shame, no judgment about that. This is difficult stuff. So you need a practitioner that can work with your trauma, whether that's from past sexual violence or from traumatic sexual experiences or from traumatic medical experiences. But these are treatable conditions. So like I said, don't give up hope. Just, seek the help that you need. Be an advocate. This is just a lot of data kind of about vaginismus, which of course at some points was considered a hysterical disorder. Often was early on related to there must be some marital problems. Maybe there was childhood sexual abuse. Maybe it's just a lack of sex education. And certainly some of those factors can absolutely play a role. But it turns out from studies that have been done and looking at areas of the brain that highlight when individuals with this condition are shown images of penetration, it really comes down to highlighting areas of fear, not disgust, but fear. And it turns out, again, that this is more of a phobia disorder that needs to be addressed using some of the techniques that, different phobias are treated with. Treatment, again, multifactorial, there's medications, there's physical therapy with pelvic floor physical therapists, there's the talk therapy, as I mentioned, and then there's always the possibility of doing some forced relaxation of those muscles using trigger point or Botox injections as well. So I do want to make sure I leave time for a conversation with the co-hosts here, but I did always like to end things with a little bit of humor. Sure, avoiding sex or self-medicating, those are acceptable ways to deal with this. But I hope this empowered you if you're dealing with pain for whatever reason, to know that there can be some answers out there for you, that there can be some treatments. If it's important to you, if you feel distressed because you're not able to have your sexual relationship that you want, if you are in distress because you're not able to complete exams that you need for your preventative health care, please seek help. And hopefully this has given you some tools to use to help in that. And that is the end of my presentation. I'll turn it back over to the amazing co-hosts.
Awesome. Thank you so much. Such great information. And I know you talked greatly about finding a provider. So let's put up, Vic, for them, the International Society for Study of Women's Sexual Health, ISWISH. And if you go to that site, there is a find a provider button there, and you can find providers who are trained in this specialty. And so if you're looking for a healthcare provider, advanced practice nurse, or a urologist or urogynecologist or specialist in this area, that's a great place to go. If you're looking for a physical therapist find how to find a physical therapist. Here's another site to go to if you're looking for a physical therapist. That is the APTA pelvichealth.org. And so I just wanted to give those resources to our listeners for sure. And there was so much great information. And I know I had taken a few notes about some things I was thinking about. I know so often my patients, that avoidance comes in with sex, and they tend to avoid sex completely. And so I know, Dr. Kellogg, you too do. So what I try to do with them is do a little bit of work with Sensate Focus developed by Masters and Johnson, and have them take intercourse off the table and try not, because the more we avoid it, it becomes this more powerful, painful event that they're so afraid of. And so I wondered what you all have done too. But what we typically do is we kind of take intercourse off the table, work on some outer course. If you're like, what the heck is outer course? Tune in October 28th, because we're going to have a great panel on outer course. But that's some of the things that I know we do, because we try to tell them we want you to have pleasure and re-engage in sex that has absolutely nothing to do with pain again. So just wondered, the two of you, if you could each speak to, maybe Dr. Kurtz, if you want to start, and Dr. Kellogg, I'd love to hear as well what you do with that.
Yeah, definitely. I think just reminding patients that sex and intimacy doesn't have to, the pinnacle of it is not having penetrative intercourse, like you said. So, just allowing them to take that, as you said, off the table, find other ways to reconnect with their partner, to keep that activity going in other ways, while potentially working on some of these treatments for them, I think is so helpful. And then, I really leave the expertise, having experts who work with Sensate Focus and, sex therapists to do that work with the patients, because that's not my expertise. I'm the expert in helping people to get through their gynecologic exams, but I'm not the therapist. So I want to, let the appropriate people do that work with them. But it's just giving permission, I think, that it's okay. And, and then when it, comes to gynecologic exams, also the work that I do, which is kind of similar to graded exposure, is just there's so much guilt, I think, that develops over time for these women with their sexual relationships, but even in the doctor's office. And just to really make it a guilt-free space. It's not your fault. This is just something that happens. And unfortunately, it's become, more complicated, but we're going to work together. And if we don't, there's no pressure to get through the end of the exam. If it takes 3 visits, if it takes 50 visits, whenever we get there, we get there. But usually we're able to be successful using that approach.
Yeah. And even I know you do as well. Sometimes I'll have them with a Q-tip test, even put their hand over mine, guide it, that they have control over that some of that exam, some of that testing, that they feel like they have real control over it, and can stop at any point, just like you said. I guess Dr. Kellogg and I are really so blessed, because I was able to do, take the counseling therapy type track as well. And I can spend that time with patients as an advanced practice nurse as well, having that certification and working with them. So we do a lot of Sensate Focus in my practice. And I know you do too, Dr. Kellogg. So I just wondered what you had to say.
So one of the things I wanted to talk about was, like, honesty is the best policy. And if you're working, if you're a woman that's got sexual pain, I find that, especially in the dating space or in the looking for a new provider space, sometimes it seems so awkward to say anything. So nothing is said at all. And I've had lots of patients that say, well, I just my partner doesn't know how much this hurts, or that it hurts at all. I just kind of just kind of grit my teeth and go through it. Or my gynecologist doesn't know either. Not really. And honesty is really, really important. And pretty much at most partners, if they knew how much it hurt, it would be a different kind of an issue. It would be, well, how can I help you? And so it's very important, I think, to help us as providers and a partner as your partner learn what's really going on. And that means to get really serious and have a talk, but have a talk clothed, fully clothed. So you're not feeling vulnerable, not in the middle of a sexual scenario or a scene, fully clothed over coffee or something to say, I really have to talk to you about this. Sometimes women develop pain over their lifespan. And so sometimes they say, well, my feelings for you, oh, dear partner, haven't changed, but my body has changed. And so I want to talk to you about this and let them know it's not a reflection of your feeling. It's just that your body's changing. Or this medication has caused this to happen that maybe they've been put on. With a provider, it's really important, with a healthcare provider, it's really important, hopefully, that you meet them with your clothing on and tell them that you've had, really difficult experiences. And if they only have 10 minutes today to deal with you, how about we just talk for 10 minutes and we don't do an exam until the next time? You can be the powerful one to say that. I would hope that providers would say, hey, how about if we just talk today and I'll examine you next time? But not every provider has the training to do that or the intuition to do that. You can lead the discussion and say, is it okay if we just talk? You want to know why that's important? Because when you're just talking to them, you get a gut feel whether you're in a safe space and you want to move on with that provider, or whether it's time to say goodbye and find another provider that will really help you. And I think you know that your gut knows that. Just use your personal power and be honest with partners and be honest with providers.
That is just such good intuitive advice. I love it. And I know you find too the power of that presence. When you speak it into the world and you talk about it, it dissipates the power it has over you. I know it is so hard to talk about the trauma, whether it's physical, emotional, whatever kind of trauma it is. But like you said, Dr. Kellogg, it's a powerful moment. And definitely, I say, you will decide if and when we do an exam and what visit that happens on, or if it ever happens in my office, because a lot of the people have had somewhat of a gynecological exam from another provider, and I don't want to put them through more trauma if I don't have to. But I explain to them I'll be looking for more specific, different things than their gynecologist that have to do with the pain if we do that exam. So I think that's really good advice and really good information. Excellent. I know, Dr. Kellogg, there had to be a lot of things that were swimming around in your head because this is so your area of expertise. So I'd just like to give you a space to talk about after Dr. Kurtzer's presentation. Anything you would like to address, talk about, expand upon?
Yeah, I would really like her opinion on the following. So many people with pain get really strong lidocaine or something to numb themselves to get through sex or to get through a GYN exam or to get through life. Why is that a good idea or a bad idea?
Yeah, I think it has to do with, those connections, right? Like we have the pain because of the perception of pain that happens, kind of the bottom exposure pain that goes to the brain, but then there's a little bit of the top down type of pain too. So we're just trying to break a little bit of the association of it. And so if somebody is able to accomplish an exam or have activity because they're numb, it takes away a little bit of the top down piece of the pain, that I can't, aspect of it. Like you can. It's just, does that make sense? It's just basically interrupting a little bit of that barrier that we create for ourselves to not feel fear around it, right? That fear associated contribution of pain and taking that away. So it is a tool that's used and that, variable efficacy, I would say, in doing it. I think it's better to do more multifactorial approaches to treating this, and that might be one of the tools that's used. But I don't think it's not going to be typically the solution for everything to suddenly go away, right? It's not like the therapeutic thing. That being said, I think there's some people that probably do have a little bit of dysesthesia, hypersensitivity of the nerves in the vulva that can be downregulated a little bit with the really high doses of lidocaine. But for vaginismus, kind of severe vulvodynia, that there's already pelvic floor tension, a trauma history due to sexual or medical trauma, usually the lidocaine is not going to be sufficient.
Yeah, I agree. Lidocaine can be a temporary fix, just like, I have other patients that say they just get really imbibe a lot of alcohol and they can, quote, get through it. Lidocaine and numbing oneself with booze or with drugs, it's a temporary fix for a long-term problem. And it probably takes, it's a little scary, but it takes more courage, but you'll be glad you did take the courage and do it, go through the sex therapy and then work with a trauma-informed counselor and a trauma-informed medical clinician. And we'll hold your hands through this. We'll get you through this. But numbing you is probably not exactly on the top of my list for things to do. For patients. And that's numbing with, again, booze, drugs, lidocaine, whatever. It's not really the answer, even though it seems like such a cool short-term fix. That's just it. It's a short-term fix. So do people really get better? Dr. Kurtzer, do people really get better from?
Absolutely. Oh, 100%. It is like vulvodynia. Well, first of all, GSM, VVA, very easy to treat, right? The more complicated vulvodynia, vaginismus are definitely treatable and correctable. But again, I will say, right, there's a little bit of that time continuum. The longer it takes for somebody to get in and be ready to address it, that's a lot of layering of years of probably repetitive pain issues or feeling uncomfortable, with the situation. And so it becomes more difficult the longer standing it's been around, but it's definitely doable. Like I said, I've had patients that are in their 40s, 50s, 60s who've never been able to have an exam or have penetrative intercourse, who've been able to, work collaborate in a multidisciplinary way. So I don't want to take credit for it myself, but by aligning all of the appropriate people to work with that individual and time, they have been able to be successful in their treatment.
That's great.
Yeah.
So exciting and wonderful when you're a part of that journey to see those people when they get to that space. I had one woman who was like, I just gave up on it. I just, but I love to swim, so that's good. And I'll never forget when she came in and she's like, okay, swimming doesn't hold a candle to the orgasms that I'm having now. And I was like, wow, I can't even tell you how much you made my day today. That we got you to that place. But like you said, I give a lot of credit to my physical therapist because there's often a muscular piece, the hormonal pieces. It takes work. And the physical therapy often takes 3 to 6 months to really do the job. Remember, it took a long time to get where you are with the pain, and it takes a long time to get back out of it, right?
Absolutely.
Sometimes longer too.
Definitely.
And the other thing is sometimes it's like working out, right? So sometimes you have to have those refresher visits too, or what I call booster visits with the
fascia takes a long time. Fascia takes a long time. My plantar fasciitis took a year to resolve in my one foot, very quickly in my other foot. So it takes a while, but so I know it's really hard to be patient, but patience is a big part of it too.
Mm-hmm.
I have a couple questions that have come through.
Okay.
The first one is, I've been experiencing pain with intercourse for years, but every time I bring it up to my provider says, everything looks normal. How can I advocate for myself when the problem is being minimized?
Yeah, I'm so sorry that's been your experience, because as I just showed you, it can be normal. Everything visibly can be normal, and it doesn't mean there isn't pain. Either the nerves are irritated, the muscles are irritated. And so I think the best thing to do in advocating for yourself is to use those resources. I would add the NVA, National Vulvodynia Association, NVA.org is another source for practitioners who know about these conditions and are going to take your problems seriously. I can't tell you how many people I have seen who've been told by their medical provider to just drink alcohol and they'll help the pain go away. Like that is not the appropriate medical advice here. And so, yeah, it
Back
just,
to your numbing, Suze. Back to the numbing. And you even have a provider recommending it. But yes, and I mean, I have had so many people come to me. I just was talking to a couple saying, oftentimes people say to me, it can, and when you look at the research, 5 to 7 providers before you get to somebody who actually gets what's going on with you with your sexual issue and is ready to help you address that sexual issue. So by the time they get to us, sometimes they're just like, no one seems to care about this. It's
But there's lots of people that do care. And so my comment is, let's take the sex part of this story out. And let's say your foot hurts. Every time you walk on your left foot, it hurts. And you go to your family doctor and he or she says, your foot looks great to me. But you know, your reality is that your foot hurts every time you walk on it. You would most certainly get a second opinion, and maybe a third and maybe a fourth. You wouldn't just say, oh, well, I must be crazy. My foot looks great. So this pain is in my head. No, it's not. It's not at all. So get another opinion, get 4 opinions, get 7 if you have to, because the reality of this is you are your own best advocate and you can just keep trying, please. Even if you live in a smaller area, you can have virtual consults for many of these issues. And I know all 3 of us have seen patients from very far away in our clinics. And then from my point of it, I just get on the phone with whoever the local docs are, and I will help coach them through caring for the patient in their own hometown. So there's help for you. But again, use your words and be honest. And if you have to get a second or third or fourth opinion, go for it.
Love it. Next question I have is coming through was that it's hard for me to talk about my past sexual trauma. And I hear this from, remember, 1 in 3 women, 1 in 5 men have experienced sexual trauma. And remember, some people aren't talking about it. So that's probably not completely accurate. I'm sure it's even more. But they said, it's really hard for me to talk about that. And I hear that over and over from my patients, even with my partner. Some of my patients have not disclosed it to their partner. How do I determine who and what I tell my partner or others? Because it's very triggering for me.
if it's triggering, then you don't have to disclose that information, certainly not to a medical provider. It can be helpful for us to know, but it really shouldn't be necessary for us to know. We really should treat every single patient with the thought that there's a potential trauma history just because of how common it is. So for me, it's not something that I need to know. I think with a partner or somebody else that you trust in your life, you'll know when you feel like it's something that you can share. And if it's still triggering for you to think about or talk about, then you're not at that place yet. And that may be an indicator that it would be helpful to work with a trauma, therapist, a therapist who specializes in trauma, so that you can feel more comfortable with, addressing that story, that bit or piece of your life that doesn't make up the whole of your life. It's just a piece of it, that how you can integrate it more into your, day-to-day existence and maybe into your relationships as well. But, plenty of people don't ever share that information with their partners, and that's okay.
Yep. I think it can be, I agree wholeheartedly. And I tell patients, you could tell me, and even if they tell me there's been trauma, I say, you can tell me as much or little as you want. That's completely up to you. It can be powerful sometimes to talk about it and to dispel the silence. But I think picking and choosing who you tell that to is really important. I love Brene Brown's work and how she says, has this person earned the right to hear and be a part of that story with you? I think that's something that I inform patients when they're trying to decide, can I tell this person? Should I tell this person? And two, I have patients who've had trauma who absolutely inform their partner, and I have patients who do not tell their partner. It is your story to tell, and only you should tell it. So I think there's a lot of things to think about disclosure. So it's a challenging thing. I'm going to go to our closing exercise in a minute, but before I do, Dr. Kellogg, is there anything else that you would like to ask or talk about from what's been said?
No, I love the presentation tonight. I want to thank Dr. Kirshner from the bottom of my heart. And thank you, listeners. If you are watching this special and you are not having any pain, but your best friend is, or your aunt is, or something like that, please share the information, because remember, the statistics are staggering. Up to, a quarter of all premenopausal women and over half of postmenopausal women have pain. So inform your friends and family, and we'll all help them together. That's it.
We will be coming back and hear from a final word from Dr. Kurtzer as well, and we will say our goodbyes. But as you know, this has been a lot to take in this evening. And so you know how we end each podcast. Well, we not exactly end. We're not quite there yet to the end. But before we end, we like to do a closing centering exercise to get you to a different space and place. So before we close, I'd like to invite you to take a moment to come back to your true, miraculous, and beautiful self. Let's begin with some deep cleansing breaths. Breathing is powerful. In your nose and out your mouth. 4 counts breathing in the mouth, in your nose, and 4 to 5 counts exhaling gently through your mouth. Make sure you're in a comfortable position. Continue this deep, relaxing breathing pattern, about 4 counts in through your nose and 4 to 5 counts as you exhale through your mouth. If it feels comfortable, place one hand gently on your heart and take a slow, deep breath in and release it fully. Let your body know that you are safe in this moment. Feel the gentle rhythm of your deep breathing as it moves through you. Remind yourself, I have every right to feel my feelings of hurt, sadness, pain, or fear. I have every right to feel those things. I do not want these feelings to reside in my body. So I release them with each breath. Now silently offer yourself these affirmations. Why is it so true? I am safe and peaceful. Why is it so true that I am safe and peaceful? Why is it so true that I am whole and not defined by my trauma? Why is it so true that I am enough and worthy of love and belonging? Why is it so true that I am worthy of healing? Put those intentions out there. They are already, as if they are already true, affirmations. They're already formed. Take one more nourishing breath, feeling the support beneath you and within you. You are miraculous. When you're ready, gently return to your awareness, to the space around you, carrying this calm presence forward into the rest of your day. Oh, we've had so much good information. I'm so excited about next week. This speaker has done so much work about your authentic self. So Vic, can you show them a little bit peek at next week?
What does it mean to return to our authentic selves? How can that deepen our capacity for love and connection? In this episode, Dr. Jeff and psychiatrist Dr. Arnab Datta discuss how reconnecting with our true selves transforms relationships. They explore how early experiences and cultural pressures can distance us from our core selves. Join us on September 16th at 7 p.m. Central Time to learn how compassion leads us back.
Well, it has been an awesome episode. Oh my gosh, Dr. Kurtzer, that presentation was phenomenal. Thank you so much for sharing your expertise. Any other words for our audience as we finish up?
No, just you're not alone. I know a lot of women going through this feel like this is just something happening to them. You're not alone. You just need to get a team behind you, and instead of fearing what comes next, just embrace the experience and get some help on your side.
I am so grateful for my two guests. I can't think of two better people to explain all of this to all of you. And these are two wonderful experts. Every time you return, Dr. Kellogg, Susan, my good friend, it is such a joy to have you here. So thank you. And I know you're returning regularly. So look forward to it, listeners. She will be on quite frequently to co-host. And Dr. Kurtzer, I know how busy life can be. Thank you so much for taking time out to share all this wonderful information. Thank you to you both.
Thank you.
Good night, listeners. Thank you most of all to you. You are what this is all about. I hope you leave this podcast knowing you are not alone. There is hope and there is help. Have a good one.
Who's Dr.